Good evening, Suresh. This is Roshni.
Good evening. Yeah.
We have our first speaker with us, sir. Could we start the session so that meanwhile other...
Yeah, we can start that because it will unnecessarily get delayed. We start. No problem.
Okay, sir. Thank you, sir. Subhash, I'm handovering session to Subhashri. Subhashri, could you start the event, please?
Yes, ma'am.
Please.
Good evening, everyone. On behalf of the International Association for Integrated Oncology, IAIO, I warmly welcome you all to today's Expert Insight session on lung cancer. This academic forum focuses on cutting-edge strategies in the management of non-small cell lung cancer, NSCLC. We will begin with expert talks, followed by an engaging panel discussion on real-world case scenarios. Before we begin, it's my privilege to acknowledge our program director, Dr. Suresh Babu MC, director and senior consultant, medical oncologist from Krishna Institute of Medical Sciences, Bangalore. Sir, thank you for lending his expertise and leadership to this initiative. His guidance has been instrumental in shaping this insightful session on lung cancer management. We are truly grateful. Now we come into the introduction and context setting, laying the foundation of today's discussions on lung cancer. I would like to invite Dr. Suresh sir to take over. Sir, over to you, please.
Thank you. I think we know the lung cancer is the most common cancer in the world today. I think with the targeted therapy and immunotherapy, things have become more easier or rather complicated for a clinician. So there are a lot of mutations coming up. There are some scenarios where you find more, complex mutations in the molecular test when you do. Then you don't know which to choose, and end of the day, it's the molecular tumor board which dictates the term which drug we are going to use. So as the drugs chances are available more and more, and the things are getting more complicated, in the interest of the patient, we must know that what drug to be given. There are some scenarios where you have both ALK and IGFR both being there, which one to choose. So all those things, come into the matter. So interpret each molecular report. I think we require a molecular oncology and pathologist to our help so that we can determine which is the way to go forward. So this, meeting was basically done to have some clearance on some of the immunotherapy and targeted therapy and other chemotherapies and how to go ahead about in treatment of lung cancer. I think with this, I think we'll give a start to the CME. Thank you. Over to the team.
Thank you, sir. Thank you for setting the stage for today. Now it's my pleasure to start the scientific program with the first topic, cure or over-treatment immunotherapy strategies in resectable NSCLC. It's my pleasure to invite Dr. Anup R. Hegde, consultant medical oncologist, KIMS Hospital, Bangalore, to present his insights. Over to you, sir. Please share your expertise.
Yeah, sure. Am I audible?
Yes, sir.
Okay. Hope my screen is being shared.
Not yet, sir.
Now it's visible. I've sent in a request to share the screen.
Can you try resharing right now, sir?
I'm not able to do it. I think it would be better if someone else shares the slides. I can present it for.
Yes, sir. Team, I will share. Hope the screen is visible, sir.
Just give me 1 second. not yet. Yeah. Not able to see the screen. The screen being shared?
Yes, sir. The screen has been shared actually. Now it's visible, sir?
Not yet. I'm not able to. Just give me 1 second.
Okay. So sorry for the trouble, sir. Can you just rejoin, sir, so that it would be helpful?
It's being shared. Where is it? Is it being shared now from my side? Is it coming?
No, sir.
Zoom meeting.
Our team has shared again, sir. Could you see the slides?
Mhm. Zoom meeting. Yeah, now I'm able to see.
Okay, sir.
Shall I start?
Yes, please, sir.
So sorry for the delay. Thank you all for joining. Thank you, Suresh Babu sir, and thank you to the organizing team for giving me this opportunity. So today we'll try to discuss a few things about the immunotherapy strategies in resectable lung cancer. And we'll try to describe which patients are actually being cured with immunotherapy and which patients are probably being overtreated with immunotherapy. Next slide. So we know that resectable NSCLC encompasses basically stage 1 to 3A, and some trials have also included selected 3B patients as resectable NSCLC. And this accounts usually for 20 to 30% of all the diagnosed cases of NSCLC, probably a bit lesser in India. This is the global data. And historically, we know that the standard of care had been surgery followed by adjuvant chemotherapy. But overall, the prognosis seems to be bad. Even with adjuvant chemotherapy, probably there is a 5% benefit over 5 years with respect to overall survival. Next slide. So even in stage 3, actually, it is a very heterogeneous disease because stage 3 again is divided into A, B, and C. And stage 3C is considered as unresectable, whereas in stage 3A we have T1A to T2B, which is considered as T1A to T2B with N1, which is considered as stage 2B, but T3, T4 with N1 is considered stage 3A, and any N2 disease between T1A to T2B is considered as stage 3A. So this is where most of the times we consider it as a resectable disease. Next slide. So the 5-year survival drops down significantly with even in stage 3, as we go down from stage 3A to 3C, the 5-year survival at the stage 3C almost is equal to what we see in stage 4 disease. Next slide. And this is, we know the data from the LACE meta-analysis, which showed that there was probably just a 5% overall survival benefit at 5 years with the use of adjuvant chemotherapy. And a similar benefit was seen even with the use of neoadjuvant chemotherapy. So not much benefit as such with the use of chemo alone. So next slide. So this is where immunotherapy comes in for resectable lung cancer. As I mentioned, there is a failure for the typical approach of surgery first, followed by chemotherapy. And microscopic cancer cells are probably already present in the bloodstream at the time of surgery. So this is the reason a lot of patients tend to recur even after chemotherapy. And we know that immunotherapy drugs work well in the advanced NSCLC patients. So the same thing has been extrapolated in the resectable NSCLC. And there is a biological basis for this, that if we attack the cancer cells in the intact tumor, this provides a diverse library of cancer-specific neoantigens. And this also, there is some data to tell that if the patient undergoes surgery initially itself, then this kind of shocks and suppresses the immune system, and this stimulates the TGF-beta and kind of attenuates the response of immunotherapy to kill the cancer cells. Next slide. So these are the approaches we have with respect to immunotherapy, that is either giving it in the form of adjuvant setting, that is after surgery. So there we have two trials mainly, that is the IMpower 010 and the Keynote 091 trial. And the other setting is using it in the form of neoadjuvant along with chemotherapy, that is in the form of Checkmate 816 trial. And then we have peri-op chemoimmunotherapy, where we use chemoimmunotherapy followed by surgery and then maintenance immunotherapy. So these are the trials which we'll be trying to discuss today. Next slide. So these are the trials in the adjuvant setting, adjuvant immunotherapy in NSCLC. So two of these are considered landmark trials, that is the IMpower 010, where atezolizumab has been studied in the adjuvant setting. And the second is the pembrolizumab trial, that is Keynote 091 trial. So these two will be discussing in detail. Next slide. So IMpower 010 basically is a randomized phase 3 trial where they try to evaluate the efficacy and safety of adjuvant atezolizumab compared to best supportive care in patients who have undergone complete resection for NSCLC after adjuvant chemotherapy. Next slide. So this is the study design. The inclusion criteria is basically patients with stage 1B to 3A NSCLC, and patients who have a ECOG performance status of 0 to 1, and those who have undergone a lobectomy or a pneumonectomy, and tumor tissue has been sampled for PD-L1 analysis. Patients went out to receive chemotherapy, 1 to 4 cycles, pemetrexed with cisplatin, or gemcitabine, docetaxel, or venetoclax, again based on the histology. And then followed by that, patients are randomized to receive atezolizumab, 1200 mg, 3 weekly for 16 cycles versus best supportive care. The primary endpoints are investigator-assessed DFS. That is, it is done in a hierarchical way, that if the patients with a PD-L1 score of more than or equal to 1% in stage 2 and 3A, if the results in that would be significant, only then it would progress to the next subpopulation. So the investigator-assessed DFS was the primary endpoint, and other stratification factors included the male versus female stage, histology, and the PD-L1 score. Next slide. So the baseline characteristics were well matched, and around 65% of the patients were non-squamous histology, and around 40% of the patients had stage 3A disease, and 30% of the patients had stage 2A disease. And they also included some patients who were EGFR and ALK positive, around 11% and 3% respectively. And around 55% of the patients had a PD-L1 score of more than or equal to 1%. And they used a Ventana-based platform, that is SP263, to calculate the PD-L1 score. Next slide. So the initial analysis for DFS in the stage 2 and 3A NSCLC with PD-L1 score of more than or equal to 1% showed a significant benefit at 3 years, that is 48 versus 60% for disease-free survival, which was statistically significant. And next slide. And if we see the subgroup analysis, there was a significant benefit, especially for patients who had non-squamous histology, and for those who had mainly the stage 3A disease. And but the significance was less for the patients who had EGFR and ALK mutation. Next slide. Next slide, please. And if you see in the overall population, the DFS in all randomized stage 2 and 3A NSCLC, irrespective of the PD-L1, there was almost a 5% difference, that is 49 versus 55% at 3 years, which was significant. Next slide. However, in the intention to treat population, not much, the benefit was not statistically significant. Next slide. If we see the subgroup analysis as per the PD-L1 status for the DFS, the maximum benefit as expected was seen for patients who had a score of more than or equal to 50%, and even for the overall population who had a score more than or equal to 1%. However, for the patients who had a PD-L1 score less than 1, the benefit was not statistically significant. Next slide. And if you see the overall survival at 5 years, there is almost 9% benefit for patients who had a PD-L1 score of more than or equal to 1%, that is 76 versus 67%. And for the patients who had a PD-L1 score of more than or equal to 50%, the benefit was even much better, that is around 17%. Next slide. And if you see the safety data, there was nothing new compared to what we know from pembrolizumab. There was a discontinuation rate of around 18%, and around 28% had to undergo a dose interruption. And grade 3/4 adverse event as such was rare. It was 7.9%. Next slide. And the common toxicity included, most commonly, the rash. Around 18% of the patients had skin rash, and followed by hepatitis, which was most commonly detected by lab abnormalities, and hypothyroidism. These accounted for the commonest adverse events. Next slide. So the final conclusion from this trial is that this was the first phase 3 trial which showed a benefit for adjuvant immunotherapy. There was a significant DFS benefit almost across all the subgroups. The OS benefit is limited to patients who have a PD-L1 score more than or equal to 1%, and it is strongest in those who have a PD-L1 score more than or equal to 50%. And there's not much benefit in patients who have a EGFR or ALK mutation, and no new unexpected safety signals are seen with the use of atezolizumab. Next slide. So this is what led to the approval of atezolizumab in the adjuvant setting for stage 2 and 3A NSCLC with a PD-L1 score of more than or equal to 1%. Next slide. Next is with respect to the use of pembrolizumab in the adjuvant setting, that is after completion of the surgery. Next slide. So the trial is KEYNOTE-091 study. Again, the inclusion criteria was similar: stage 1B to 3A NSCLC who had undergone a complete R0 resection, and the tumor had to be tested for PD-L1. The patients had to receive an adjuvant chemotherapy, again based on the indications, between 1B to 3A, and the number of cycles were limited to up to 4 cycles. Following that, the patients were randomized to pembrolizumab 200 mg 3 weekly for 18 administrations compared to placebo. The primary endpoint in this was DFS in the overall, as well as the population with had a PD-L1 score more than or equal to 50%. Next slide. So if you see, the almost all the patients went on to receive chemotherapy. Only 15% of the patients, especially those who had a stage 1B disease, did not receive chemotherapy. Next slide. So the benefit with respect to DFS was significant at 18 months, that with a difference of around 9% for DFS in the overall population. Next slide. However, contrary to what was expected, the DFS was not significantly different based on the PD-L1 score. So even for the population where the PD-L1 score was more than or equal to 50%, there was not much statistically significant benefit, which means that as such, for pembrolizumab, PD-L1 does not seem to be a very reliable marker for benefit in the adjuvant setting. Next slide. So if you see the subgroup analysis, patients who had non-squamous etiology tend to do better compared to the squamous etiology. And for patients who had stage 2 in this setting tend to do better compared to those who had 3A or 1B disease. And there was no proper correlation with respect to the PD-L1 score. Next slide. And the OS data is yet to mature. As of now, in the follow-up 18 months, as such, not much significant OS benefit is there with the use of pembrolizumab. Next slide. The adverse events, again, around 20% of the patients had to undergo a treatment discontinuation, and the treatment interruption rates was around 38% compared to the placebo, which was around 25%. Next slide. So the most common adverse event, again, as expected, most commonly it was hypothyroidism and hyperthyroidism. And also some patients had to go through pneumonitis and severe skin reactions, but most of the reactions were grade 1 or 2. Next slide. So the conclusion from this trial is that there is a significant DFS benefit in almost all the subgroups which were studied. the OS data is immature. So based on the DFS benefit, pembrolizumab was approved in the adjuvant setting, regardless of the PD-L1 expression. Next slide. Next slide. Coming to the neoadjuvant setting, next slide. So CheckMate 816, this is the main landmark trial, which studied the role of neoadjuvant nivolumab with chemotherapy. The inclusion criteria included patients with 1B to 3A disease with an ECOG performance status of 0 or 1 and no known EGFR or ALK mutations, randomized to Nivo 360 mg plus chemotherapy versus chemotherapy alone for 3 cycles, followed by surgery and then optional adjuvant chemo and/or RT based on indication. The primary endpoints for this trial was pathological complete response and event-free survival. Secondary endpoints being major pathological response, overall survival, and time to distant metastasis. Next slide. So the response criteria was based on the pathological complete response or the major pathological response. PCR is nothing but no visible residual viable tumor cells. And major pathological response is less than 10% microscopic cancer cells on the final primary tumor histology. Next slide. So in the Nivo plus chemo arm, around 24% of the patients achieved a pathological complete response, whereas it was around 2% in the chemo alone arm. Next slide. And if we see the event-free survival at 2 years, it was 63 versus 45%, which was statistically significant. Next slide. And if you see the subgroup analysis, it correlated with the PD-L1 score. For those who had a PD-L1 score more than or equal to 50%, the benefit was the highest, followed by those who had an overall score of more than or equal to 1%. And those who had a TMB or high TMB also tend to do better with nivolumab plus chemo compared to chemo alone. Next slide. And if we see the overall survival data, at 2 years, the difference was around 12%, that is 82 versus 70% with respect to overall survival. Next slide. And with respect to the adverse events, as such, no new alarming signals were seen with the use of Nivo plus chemo. Both the arms had similar adverse events. Next slide. Next slide. So this is what led to the approval of nivolumab in combination with chemo in operable NSCLC. Next slide. Then followed by that, there was the 3-year update, which showed that at 3 years, there was continued benefit with respect to EFS, that is 43 versus 57%. Next slide. And even the subgroup analysis continued to show that patients who had a higher PD-L1, that is more than or equal to 50%, had a higher benefit compared to those who had a PD-L1 score of less than 1%. Next slide. And the benefit was seen irrespective of the type of surgery which was done, irrespective of whether a minimally invasive or a thoracotomy. Nivo plus chemo tend to do better than chemo. Next slide. And even the patients who had a lobectomy or a pneumonectomy, the Nivo chemo arm tend to do better compared to the chemotherapy alone. Next slide. If you see the time between the date of randomization and the first date of distant metastasis or the date of death, again, it is much better in the Nivo chemo arm compared to those who receive chemo alone with a hazard ratio of 0.55. Next one. So if you see the safety profile, again, Nivo plus chemo, even in the long-term follow-up, did not show much difference with respect to the adverse event compared to chemotherapy. Next slide. The recent 5-year update from ASCO 2025 showed a sustained overall survival benefit of around 10% at 5 years, that is 65 versus 55%. Next slide. And if you see the overall survival with respect to each stage, that is, the benefit is higher with the higher stage. So those who had a stage 3A disease had a much better benefit with the use of Nivo plus chemo compared to chemo. And with respect to PD-L1 expression, patients who had a PD-L1 expression of more than or equal to 1% had almost 20% benefit with respect to the overall survival compared to those who had a PD-L1 expression less than 1%. Next slide. And this study also evaluated the overall survival in patients who had a pathological complete response compared to those who did not achieve a pathological complete response. So patients who were given Nivo plus chemo and achieved a pathological complete response almost had a 100% 5-year overall survival, and compared to those who did not achieve a pathological complete response. And the hazard ratio for death was extremely significant, that is 0.11. And even if we take with respect to the ctDNA, the overall survival in patients who achieved a ctDNA clearance was much better compared to those who did not achieve a ctDNA clearance. Then the hazard ratio for that was 0.38. Next slide. And they also did a correlation to see whether the circulating tumor DNA correlates with the pathological complete response. And those who received Nivo plus chemo tend to have a higher ctDNA clearance of 56%. And most of them, again, around 46% of those patients tend to achieve a pathological complete response. So this is much higher compared to what we see with chemo alone. And the survival is much better for those who achieve both the ctDNA clearance as well as the pathological complete response, that is around 100%. Next slide. So the takeaways from Checkmate 816, which is a landmark trial, is that Nivo plus chemo tends to significantly improve the survival, and the benefit is seen across all the subgroups. The pathological complete response rates tend to have a good correlation with how the patient will have prognosis, and even the ctDNA clearance has a significant prognostic significance. And also there is a correlation between the ctDNA clearance as well as the pathological complete response. Next slide. Next, coming to the trials on peri-op immunotherapy. Next slide. So AGN trial, as we know, was one of the trials where they tried to evaluate the role of durvalumab in the peri-op setting. So patients here included were slightly more who are locally advanced. So it was stage 2A and up to 3B with N2 were included in the trial with confirmed PD-L1 and documented negative EGFR ALK mutations. Patients were randomized to receive durvalumab with chemo for 3 weekly for 4 cycles, followed by surgery, and adjuvant durvalumab, that is 4 weekly for 12 cycles. And the primary endpoints were pathological complete response and event-free survival. Next slide. So the event-free survival at 2 years was significant with the use of durvalumab with chemo compared to chemo alone. That was 63 versus 52%. Next slide. And if we see the subgroup analysis, again, with respect to disease stage, those who had a stage 3A disease tend to do better compared to those who have either 2 or 3B disease. And with respect to PD-L1, the higher the score, the better were the chances of response to immunotherapy. Next slide. The pathological complete response rates, which were seen, was 17% with the use of immunotherapy compared to only 4% with chemo alone. And even the major pathological response rates were much higher, that is 33 versus 12%. Next slide. And again, the PCR subgroup analysis showed a similar scenario with a better response with the higher PD-L1 score. So to patients who had a PD-L1 score more than or equal to 50% tend to have a much better chance of achieving a pathological complete response compared to those who have a score of less than 1%. Next slide. And the safety profile, as such, the grade 3 or 4 adverse events were similar between both the arms, durvalumab or placebo. Next slide. So this trial showed that there was a significant benefit with respect to the pathological complete response as well as the event-free survival. And this was the reason where durvalumab was approved in the peri-op setting in resectable NSCLC. Next slide. So next was to evaluate the role of pembrolizumab in the peri-op setting. So this was the Keynote 671 trial. Similar eligibility criteria with stage 2 to 3B, patients who had to undergo surgery, and patients had a good performance status of 0 or 1. The randomization was between pembrolizumab 200 mg plus gemcis or pemetrexed cisplatin based on the histology for up to 4 cycles, followed by surgery and adjuvant immunotherapy of 13 cycles, pembrolizumab 200 mg 3 weekly. And the primary endpoints being event-free survival and overall survival. Secondary endpoints being PCR and major pathological response. Next slide. So the event-free survival at 2 years was significantly higher with those who received pembrolizumab, that was 62 versus 40%. Next slide. And if you see the follow-up data, again, even at 4 years, the benefit seems to be sustained. That is 51% versus 28% at 4 years. Next slide. And if you see the subgroup analysis, the benefit seems to be across all the subgroups, irrespective of the histology, squamous or non-squamous, or the stage of the disease, or the PD-L1 score. The benefit seems to be sustained across all the subgroups for the benefit of pembrolizumab. Next slide. And if you see the pathological complete response, it was around 18% compared to 4% in the placebo arm. And the major pathological response was 30% versus 11%, both of which were statistically significant. Next slide. And they also did an analysis of the event-free survival based on the pathological response. And as expected, patients who had a pathological complete response and those who received pembrolizumab tend to do better compared to those who did not achieve pathological complete response or did not receive pembrolizumab. Similar was seen even with major pathological response criteria. Next slide. And if you see the 5-year overall survival follow-up data, again, a significant difference, 64% versus 53%, almost a 10% difference with the use of pembrolizumab, which led to a 26% reduction in the risk of death. And with respect to the event-free survival, also 49.9 versus 26% with the use of pembrolizumab, which led to a 42% reduction in the risk of death or event. Next slide. And for the subgroup analysis, again, also showed that irrespective of the PD-L1 score, the benefit was seen across all the subgroups and also irrespective of the histology. Although the benefit here was slightly more for squamous compared to non-squamous histology. Next slide. With respect to adverse events, as such, overall, there were around 25% of the patients had immune-mediated adverse events. However, grade 3 to 5 were pretty low, that is 5.8%. And next slide. The more common immune-mediated adverse events were hypothyroidism, followed by hyperthyroidism, pneumonitis, and skin reactions. However, most of them were limited to grade 1 or grade 2 immune-mediated adverse events. Next slide. And again, if you see the EFS as well as the OS, 5-year, as I mentioned, EFS 49 versus 26%, and for the overall survival, 64 versus 53%. And the benefit was seen irrespective of the subgroup, and higher the PD-L1 score, better is the hazard ratio. Next slide. So the key takeaways from the Keynote 671 was that there was EFS benefit across all the subgroups, and the pathological complete response and the major pathological response rates were higher with the use of pembrolizumab, and there is a significant OS benefit at 5 years. The adverse events, as I mentioned, not that we have not seen before, and this led to the approval of pembrolizumab as a peri-op for a treatment of resectable NSCLC with a stage of 2, 3A or 3B with N2 non-small cell lung cancer. Next slide. Next came the NADIM-2 trial, which this is basically a phase 2 trial on the background of the CheckMate 816, where neoadjuvant nivolumab was given with chemotherapy. Here, they tried to evaluate a similar protocol, that is neoadjuvant nivolumab plus chemo versus chemotherapy alone in patients with stage 3A and 3B non-small cell lung cancer. Next slide. So the inclusion criteria, 3A and 3B non-small cell lung cancers, which were potentially resectable, EGFR and ALK had to be negative. Patients were randomized 2:1 to receive Nivo plus Paclitaxel versus Paclitaxel alone. Patient underwent surgery, and in this, unlike the CheckMate trial, patient went on to receive even adjuvant nivolumab for 6 months, that is 480 mg 4 weekly. Next slide. The primary endpoint in this again was pathological complete response, and the secondary endpoints were major pathological response, overall response rates, OS, and PFS. Next slide. So the baseline characteristics were well matched. Histologies included adenocarcinoma, adenosquamous, squamous, large cell, and also undifferentiated. And all the stages were matched between the two arms. Next slide. And the pathological complete response was much high, that is 36% versus 6.9% seen in the chemotherapy alone arm. Next slide. And if you see the major pathological response, again, was much higher, 52 versus 13% with Nivo chemo compared to chemo alone. And also the overall response rates were much higher. That is, objective response rates were much higher, 75 versus 48%. Next slide. Similar was seen also with the objective responses much higher with Nivo plus chemo compared to chemo alone, 93 versus 69%. Next slide. And as per the safety data, 25% of the patients in Nivo plus chemo arm had grade 3/4 adverse event compared to around 10% in the chemo alone arm who had grade 3 or 4 adverse event. No patient had a grade 5 adverse event. Next slide. So they also did a predictive biomarker for the response to see which patients are higher chance of achieving a pathological complete response. And that correlated well with the PD-L1 score. Those who had a score of more than or equal to 50% had almost a 60% rate of pathological complete response. And it was much less, that is 15% in those who had a PD-L1 score of less than 1%. Next slide. So the conclusion was that there is a significant PCR improvement with the use of neoadjuvant nivolumab to chemo compared to chemo alone. And there was no impediment to undergo surgery even after receiving nivolumab in the neoadjuvant setting. And the safety profile was tolerable. Patients with a PD-L1 score of more than 50% tend to do much better, and it has a predictive value for achieving a pathological complete response. Next slide. So after looking at all these trials, I think these are the key answers which we are yet to have. That is adjuvant immunotherapy necessary after receiving neoadjuvant chemoimmunotherapy? As we saw in the CheckMate 816 trial, patients received neoadjuvant nivolumab but did not receive adjuvant nivolumab. So, but patients had a very significant pathological complete response and also a good survival. And the second question is, for patients who achieve a pathological complete response, can we go for a de-escalation? And similar question even for those who achieve ctDNA clearance, even for them, if we can undergo a de-escalation. So moving forward, I think more trials will focus on improving the cure rates, but also trying to identify whom we can safely de-escalate immunotherapy, mainly because of the adverse event as well as because of the cost. Next slide. So immunotherapy now has moved into the early stage, NSCLC, and neoadjuvant strategy improves the pathological complete response and event-free survival. Peri-op strategies like the AGENT protocol or the Keynote 671 protocol, I think, are more useful for patients who have large primary tumors and bulky N2 disease. Selecting the patient is more important. We have to see what are the driver mutations, the PD-L1 expression, TMB, probably the stage and resectability, and the patient age, fitness, and comorbidities, all have to be taken into consideration. Next slide. And probably the future, we may come up with a composite predictive model to include multiple factors, that is like PD-L1, TMB, the ctDNA clearance, tumor genomics, as well as probably some amount of AI, which like immunodiff score, which will help us to identify which patient will be actually benefiting with immunotherapy and for which patient we can safely avoid that immunotherapy. Thank you. Next slide.
Thank you for your insightful presentation, sir. All the participants drop the question in the chat box and it will be taken off at the end of all the sessions. Now we invite Dr. Animesh Agrawal, Consultant Medical Oncologist, Apollo Hospitals, Lucknow, to share insights. Sir, over to you, please.
Good evening, everyone.
Good evening,
Thank
sir.
you for the kind invitation for participating in this academic fiesta, I would say. I mean, delving deep into just one aspect of lung cancer. So perioperative therapy for resectable disease. We have just had an exhaustive discussion on immunotherapy. And now we will proceed to one on the role of targeted therapy. So essentially, we know that we are doing an NGS for a lot of our patients. And while it has been the SOC for a while now for advanced disease, I shall be talking about what we are doing about these agents for our patients with resectable disease. Are my slides visible?
No, sir.
Well, I did share my slides. Let me try again. Okay.
So is there any issue? Dr. Anmisa?
I think sir is joining, but it's better request sir to disconnect once again and join. I think it will work out.
Yes, sir.
Rashni sir has joined actually.
Yes, sir.
Jewelry part కూడా వేయాలండి.
Hello. Hello.
So you are audible, sir.
So apologies for the hiccup. Are my slides visible?
Yes, sir.
So, right. So let's not waste any further time. So I will be talking about the role of, just confirming once again, my slides are visible and I am audible, correct?
It's not on the full screen, sir. The slides are showing the other brieflies also.
It's not showing the correct.
నాను కొంచెం కిందకి పెట్టు.
How about now?
Perfect, sir. Thank you.
Right. So EGFR and ALK are essentially what we talk about because they are by far the commonest of the actionable mutations, and especially EGFR because of course ADORA does hog all of the in the neoadjuvant or the adjuvant setting. Hello.
Yes, sir.
Hello. Yeah. Sorry.
You're audible, sir.
Yeah. So for neoadjuvant setting, a lot of work has gone on for using the first and second generation TKI, predominantly the first gen TKIs, and a lot of data with erlotinib. Typically, we can see starting as early as 2012 and as recently as 2023, we have data with neoadjuvant EGFR first and second generation TKIs. The typically duration of therapy has been ranging anything between 1 to 2 to 3 months, and in some instances it has even been pitted head to head against chemotherapy, and a couple of interesting trial designs. So patients even underwent radiation in ASCENT, for instance. So this is the kind of heterogeneity, so to speak, we have in the neoadjuvant setting. All of this data is, however, phase 2. We will be talking briefly about NeoADORA as well. And we are essentially talking about all patients who had resectable disease, and a lot of these cases, they were single station N2 resectable disease. And the common trend across all of these trials, we find an overall response rate ranging anything between 40 to 70%, which is in fact the kind of numbers we are accustomed to seeing in phase 3 trials with these drugs for advanced disease. And of course, the resectability is a whole different question. So, for instance, the Lara Guerra et al. Paper, 36 patients with stage 1 disease, 1 month of gefitinib. Now, I would not be very comfortable if 1 month of gefitinib was given in stage 1 disease. For what it is worth, of these 36 patients, when they eventually underwent resection, around 10 patients actually had stage 2 and stage 3 disease. So possibly it was due to progression even. So when a lot of heterogeneity across these studies, and the efficacy, while it was there, definitely for resectable disease, the results were not where we would like them to be. With afatinib, the results were slightly better, an overall response rate 60 to 70%. And in ASCENT, even around 7 out of 10 patients who proceeded to surgery had a major pathological response. But considering the fact that these are patients with resectable disease we are talking about, possibly a surgical resection happening in anything less than 60 to 70% of patients of the ITT population is probably not acceptable. Coming to the adjuvant space, of course, apart from ADAURA, which I have kept at the end, and we will be talking about it in some detail. So the first couple of trials that were reported were the BR19 and the RADIANT. So these were large phase 3 efforts, 500 patients, 1,000 patients. However, these trials did not select for EGFR mutations, and BR19 had only 15 such patients. The RADIANT had around 160 such patients. The BR19 readout, for the patients who had EGFR mutations, I'm not sure what to make of this. Only 15 out of 500 patients had EGFR mutations, so these numbers are probably not very reliable. In RADIANT, of course, the numbers were more along the lines of what we like to see. So a clear DFS advantage, a hazard ratio of 0.6. And I suppose in a modern era, 10 years ago, this data was not considered. Today, we might be talking differently. Have our standards changed? I don't know the answer to that question. Coming to the other data that we have, and again, mostly all phase 2 data. So the SELECT trial, the EVAN, the CORIN, CTOG, the IMPACT, and EVIDENCE. So these are all trials, some of them running multicentric international trials, a lot of these Chinese trials. So we also have a couple of trials with icotinib in there, but a very mixed bag in terms of results. So starting with the SELECT trial, we find that 2 years of adjuvant erlotinib gives us a 5-year DFS of nearly 60%, a 5-year OS of around 86%. But then that impressive 5-year OS includes 45% patients with stage 1 disease. Coming to the EVENT trial, now this by far is the trial which was in favor of giving erlotinib for these patients. 100 patients randomized to receive either erlotinib or chemotherapy. So patients on the chemotherapy arm did not receive a TKI, and the 5-year DFS was 48% in the TKI arm. For the chemotherapy arm, the 5-year DFS was practically nil, so it was not evaluable. And the OS was also statistically significant. However, this OS was not actually a planned endpoint, not to mention that this was a very small phase 2 study. The CORIN and EVIDENCE, now these were icotinib-based trials, 1 and 2 years respectively. Now, both trials found a significant improvement in DFS. So the 5-year DFS of 90% with icotinib and a 5-year OS of 98%. Now, that is a number I find scarcely believable. Even in stage 1 breast cancer, we hardly get these numbers. And even in ADAURA, so for stage 1B, the 5-year OS is at around 93-94%. We will be coming to those numbers in a bit. Coming to the other Chinese data, so the CTOG adjuvant trial, gefitinib. Now, this is one trial where gefitinib failed to find an impact. So while the median DFS and the median OS seems numerically superior, the statistical analysis showed that it was in fact not so, and the gefitinib essentially in the adjuvant setting failed. Also, in the impact study, the DFS difference was not significant. So gefitinib seems to be failing the adjuvant test, at least in the CTONG and the impact studies. So essentially, what I want trying to get at here is that across the adjuvant setting as well, with the first and first generation TKIs and icotinib, I suppose, and acotinib, because it is confined to China, we do not really have any meaningful, consistent benefit for these drugs. And which is probably why we have not used it in the adjuvant setting routinely for our patients. And this is where ADAURA comes in. And of course, not just ADAURA, we will also talk about some of the adjuvant data. In the ALK setting, we do not have as much data in the ALK mutated space. So I will just talk about some of the phase 3 data that we have. So for ADAURA, I mean, we are all familiar with this data by now. A phase 3 study randomized nearly 700 odd patients to receive either adjuvant osimertinib or placebo. Adjuvant chemotherapy was optional, and patients were stratified by stage EGFR mutation and their geographical predisposition, so whether they were Asians or non-Asians. Importantly, OS was a secondary endpoint. Patient characteristics fairly well balanced, around 1/3 each of stage 1, 2, and 3, and around 60% patients on each arm had received prior chemotherapy. The remaining characteristics were fairly well balanced. And this, of course, is the DFS curves that had all of us going both simultaneously gaga. So, I mean, that hazard ratio of 0.27. So this is the 4-year follow-up data that was published in the JCO. And simultaneously, we were all a bit concerned because of the shape of these curves, this I-shaped curve. So once the osimertinib is stopped, the difference between the PFS DFS curve seems to be maxing out. So 90 versus 55, 85 versus 44, and then the difference starts narrowing as we go on further with the follow-up. And this, of course, raised the concern: are we just delaying the inevitable? So, I mean, instead of stopping at 3 years, should we be doing what we do in breast cancer? I mean, tamoxifen, letrozole, we are giving these drugs for 5, 7, even 10 years. So, is that what is required? So, that was the concern. And of course, we were waiting for the further follow-up data. This, of course, is the forest plot for the DFS. And yes, the benefit was seen across all subgroups. Maximum benefit was for patients with stage 3 disease and with exon 19 deletions, but pretty much across the board, the benefit was there. And then, of course, came the OS data, which is where things changed. The 5-year overall survival in the ITT population is 88 versus 78%. We can see the survival curve start to separate out at approximately the 1-year mark, and then the separation continues to widen with time. And once we start looking at this disease-wise stage benefit, we find that the benefit is there across all stages. So 1B, 2, or 3. However, we can find that the 95% confidence intervals in both stage 1 and stage 2. So that, for your reference, would be the 2 survival curves on the top. So the 95% confidence intervals in both cases is crossing unity, which would suggest that the significance has not been reached. Again, we remember that OS was a secondary endpoint, and this was just a subgroup analysis of that secondary endpoint. So with that disclaimer aside, patients with stage 3A seems to find the maximum benefit of adjuvant osimertinib. What about the role of chemotherapy? So we remember, when we think back, that around 60% of patients receive chemotherapy on ADAURA. And one of the questions that we wonder about is the chemotherapy necessary? Can we just do away with the chemotherapy and our systemic therapy would be the EGFR TKI, that is osimertinib alone? And we find that for patients who did receive adjuvant chemotherapy, the OS was 87 versus 77%. So osimertinib combined with chemotherapy, for patients who do not receive chemo, we find it is 80 versus 66. And this would seem counterintuitive. Patients who do not receive chemotherapy would more likely be the ones with earlier stage disease, because of course chemotherapy was at investigator discretion. So we find that the addition of adjuvant chemotherapy is definitely adding to it, and it is something that would seem intuitive as well in one regard. I mean, chemotherapy is something that has been proven over the last 3 to 4 decades. We have phase 3 studies, we have meta-analysis to tell us that chemotherapy definitely adds some time. And based on the data we have from ADAURA, it would seem that we cannot do away with chemotherapy just yet. This, of course, is the forest plot for the subgroup analysis, and it reflects all the data that we have just talked about. Here is where the data gets slightly murky. So the OS advantage, where it is narrow, so the stage 1 and the stage 2s, we find that upon progression, patients who were on placebo, so around 162 patients, so around 162 patients received further subsequent therapy, but only around 43% of patients received osimertinib upon progression. And this by far has been the biggest criticism leveled against this trial. So is the OS benefit that we are seeing a spurious one, or is it a genuine overall survival benefit? The whole debate between the DFS and the OS is far too big to be taken on upon this particular discussion. But I will say that my take on this is that the DFS alone is worth the adjuvant osimertinib, considering the fact that the patient would be living for a very long duration disease-free, even if the subsequent relapse and possible progression may give them a much lesser time. Living longer without disease is possibly better than living for longer with disease. The toxicity profile is fairly benign, I would say. We are used to far worse with drugs such as erlotinib and afatinib when we try giving them at full doses. And compared to those, osimertinib is much easier to handle. Nevertheless, there were around 13% patients who had to discontinue the drug, around 12% patients who required a dose reduction. But overall, around 85 to 90% of patients were able to take the drug without any dose reductions or discontinuation. So ADAURA, is it practice changing? Definitely. But I would say that while it is definitely the case for stage 3 disease, for stage 2 disease, I am leaning towards yes, shared decision making would be the norm. Similarly, for stage 1, maybe ADAURA 2, which is enrolling only stage 1A2s and 1A3s, will shed some more light. So, if ADAURA 2 is able to show a survival benefit, I would be much more comfortable using it for 1Bs and stage 2s. Similar trial design, ALINA, so patients with resected stage 1B to 3 disease, and we just switch out EGFR for ALK, we switch out the osimertinib for alectinib, and voila, we have ALINA. Instead of 3 years, we are using 2 years of alectinib. Primary endpoint DFS, secondary endpoint CNS DFS, overall survival and safety. Again, fairly well balanced arms in both in this trial. Interestingly, patients on the chemotherapy arm did have slightly more males compared to females. So the male-female ratio was flipped here. But other than that, the arms were well balanced. And this is the updated DFS data, which was published recently. So the median DFS was not reached with alectinib, as would be expected for patients with ALK-positive tumors. And with chemotherapy, the median DFS was 41 months. And we should remember that, I may have forgotten to mention, patients on the experimental arm in ALINA did not receive chemotherapy. So this trial will not be telling us whether we were, at least not telling us even indirectly, whether chemotherapy can be skipped altogether. So when the subgroup analysis were done, it's a very nice looking forest plot. Pretty much all subgroups seem to be benefiting across the board. When we start looking at the stage-wise data, these are the DFS curves that we have. And this is the numerical data. As expected, patients with 1B disease seem to have the fewest failures and the best and the longest DFS, both at 2 and 3 years. So 92%, around 85%, and then around 90% again for stage 3. Now, this seems to suggest that the alectinib will negate will actually modify the disease biology and give us a very good survival, while the chemotherapy arm, 70% for stage 1, around 65% for 65% for stage 2, and around 50 to 60% for stage 3. So the chemotherapy is not modifying the disease biology, alectinib is, and the DFS is showing up accordingly. The recurrence patterns I found somewhat interesting. So, I mean, typically we would say that the ALK inhibitors do have some sort of CNS efficacy, although of course nothing quite does what lorlatinib can. But nevertheless, the propensity of ALK positive disease for the CNS shows up even in the recurrence patterns, despite patients having received 2 years of alectinib. And so most of the distant recurrences, so of 3 plus 2, 5 patients with distant recurrences, out of these 4 had CNS disease. So the propensity of the brain continues, but other than that, the numbers for recurrence are lower, unsurprisingly. As far as the subsequent therapy is concerned, much better than what we saw with ADAURA. Most of the patients did receive an ALK TKI, and of the ALK TKI, if around 43, if around 38 patients have received further disease treatment, then around 33 patients have received either alectinib or lorlatinib. So that would suggest that they have received at least the same or even better. So the crossover is definitely a much better, much more desirable in ALINA. Of course, we do not have the mature overall survival data, so we will find that out with time. Toxicity profile, again, similar to what we have been experiencing with alectinib. I must confess, most of my experience is theoretical. From whatever little I have seen in my clinic, the data seems to be, it seems to match up to the data that we find. Some transaminitis, one patient with a bilirubin increase. I'm talking about my own clinical experience, but typically well manageable. Before I move on to the conclusions, I will also talk about the ELEVATE trial. So this is another phase 3 study. This was for ensartinib, similar design to ALINA. I will not dwell on too much details, but suffice to say that the DFS at 2 years on ELEVATE is 87 versus 57%. So not as impressive as one would like, as one has seen in ALINA, but definitely the benefit still seems to be there. Now, this is a trial that I am putting up because of the whole debate around first, second, third gen drugs, right? So E4512 based on the Alchemist lung cancer platform. So the E4512 used crizotinib versus observation, and we can see that the DFS curves and the OS curves are both pretty much overlapping and crisscrossing. The benefit is not significant. Some miscellaneous comments based on the exploratory analysis of these trials. So, one, osimertinib rechallenge post ADAURA is likely to work. We have a poster that was presented at ESMO in 2025, and on that poster, around 6 patients who had a relapse, all 6 were rechallenged on osimertinib. 1 patient relapsed after 2 years. The other 5 continue to be on osimertinib. So osimertinib rechallenge, even post-adjuvant osimertinib, seems to be working. Secondly, in a paper published in Nature last year, tumor-informed ctDNA-based MRD detection does predate radiological failure. So there is nothing new there. We know that is the case pretty much across the board for almost all diseases. But the false negatives are at around 35%. So how do we incorporate that into our clinical practice is still up for grabs, up in the air a bit. Coming to ALINA, nothing surprising there. TP53 mutations confer a poorer prognosis. Some other common coexisting mutations do not seem to impact outcomes. Is ALINA practice changing? Probably. Shared decision-making will, as always, be the norm, but of course, we wait for OS data. Coming for the EGFR and ALK data for the neoadjuvant setting, this should not take too long because, first of all, a phase 3 study with MPR as the primary endpoint was slightly surprising to me, but the data is what it is. But a straightforward trial design, patients were to receive either osimertinib, chemo plus osimertinib, or chemo alone. This was followed by surgery and then adjuvant treatment. While this trial was enrolling, ADAURA data did come out. Adjuvant osimertinib was made available to all patients on this trial, and around 90-91% patients on all 3 arms did receive adjuvant osimertinib. So the patient characteristics well balanced in both arms. It is the MPR that is of primary interest to us. So whether the patients receive chemotherapy or not, if they received osimertinib, so OSI plus chemo and the OSI monotherapy arms, the major pathological rate was similar, 26% and 25%. Patients on chemotherapy alone, as we know and expect, do not have much of a pathological response. And while the EFS is far immature, only 15% of the events have occurred. So far, at least numerically, the number of events is much lower in the osimertinib arms. So what do we do with NeoAdora? I mean, promising results, but we do not have any oncological outcomes. Plus, we have the familiar questions: do all patients need it? Do some patients need it? Who does not need it? And we do not know how to answer these questions. What is the optimal duration of therapy in the neoadjuvant setting, in the adjuvant setting? Again, we do not know the differential benefit. So the when Dr. Atul was just talking about the immunotherapy trials, same question that needs to be answered here as well. So what is the differential benefit of neoadjuvant versus adjuvant component? As this trial reads out later, we will be asking ourselves these same questions. And what is the actual role of MRD? So essentially more questions than answers. We have a phase 2 study for alectinib, only 33 patients, but simple enough trial design. 8 weeks of alectinib, patients went on to surgery, and then 2 years of adjuvant alectinib. Again, a primary endpoint of MPR, but this is a small phase 2 trial. This is, of course, the waterfall. Around 2/3 of patients found a partial response, and only one patient had progressive disease. Importantly, the major pathological response, which was the primary endpoint, is almost 50%. Should we do it? No idea. Further data, does the post-progression therapy change things? For ADAURA, in my opinion, no. For as flawed as that post-progression therapy is, I believe that wide apart DFS curves clinches it for us. For ALINA, similar arguments. However, OS will answer some more questions. What about the other drugs for these mutations? Osimertinib so far is in a class of 1. The Chinese Me Too drugs haven't yet come to the world, and we will find out later. For ALK, it is a bigger question whether lorlatinib can be superior. So we don't really know what will happen with lorlatinib into the equation. What about the other actionable mutations? I mean, this is just EGFR and ALK. So in theory, pretty much every single actionable mutation should demonstrate the same DFS benefit, if not OS benefit as well. My conclusions after all of this data is that, number one, adjuvant therapy is definitely here to stay. However, all drugs don't work. We have seen that the drugs, especially the first-gen drugs. So in case of ALK inhibition, crizotinib. In case of EGFR inhibition, pointedly gefitinib. All drugs definitely don't work, but definitely the newer drugs do seem to be doing it for us. As for the neoadjuvant and perioperative therapy, we still need a lot more data and a lot more maturity, a lot more follow-up. So is it ready for prime time? Not quite, but possibly in the foreseeable future. Thank you.
Thank you, sir. Thank you for your insightful presentation. So now we move on the last session, which is panel discussion. I would like to invite the moderator, Dr. Tamoji Chaudhary, Senior Consultant at HOD Department of Medical Oncology, Meherbai Tata Memorial Hospital, Jamshedpur, Jharkhand. Along with him, I also welcome panelists, Dr. Jovita Martin, Medical Oncologist, Sri Ramachandra Medical College and Hospital, Chennai, Tamil Nadu. Dr. Shushil Kumar, Consultant Medical Oncologist, American Oncology Institute, Frisian Cancer Care, Raipur, Chhattisgarh. Dr. Neelam Singh, Assistant Professor, AIIMS, Bhubaneswar. Dr. Aparna Dhar, Molecular Oncologist, Max Healthcare, Delhi. Dr. Karthik S. Tyagarajan, Consultant Radiation Oncologist, VS Hospital, Chennai, Tamil Nadu. Now I would like to hand over to the moderator, Dr. Tamoji Chaudhary. Sir, over to you, please.
Good evening and thank you. Thanks for this opportunity. Thanks to Suresh Babu sir for this invitation. And so for next 20-25 minutes, we'll just discuss few basic aspects regarding managing classic EGFR mutation positive advanced metastatic NSCLCs. And again, thanks to all our esteemed panelists, Dr. Jovita, Dr. Shushil, Dr. Neelam, and Dr. Karthik for joining with us today. And so as we know that way back in 2004, the sensitizing EGFR mutations have been detected as a predictive biomarker for the management of advanced metastatic NSCLCs. And over the last 2 decades, more than 2 decades, there is a considerable amount of evolution in the therapeutic landscape regarding how we treat this disease and how we really target these sensitizing and resistant EGFR mutations. So we'll focus on all the therapeutic options which are available, not only in the first line setting, but also in the subsequent line of the setting, and how really we choose regarding more than one recommended therapeutic options, depending on our clinical scenarios. That will be the main focus of discussion of today. Next slide. So this is the current NCCN guideline, and if you focus on what are the recommended options for first line classical EGFR mutation positive advanced metastatic disease, then there are 3 category 1 preferred options. Number 1 is a third gen EGFR TKI, which is a monotherapy, which is osimertinib. Next is a FLAURA2 regimen, that means osimertinib plus platinum pemetrexed regimen, and third one is the MARIPOSA regimen, another different third gen EGFR TKI, which is lazertinib, along with an bispecific monoclonal antibody amivantamab, which targets both the EGFR and the MET inhibition, causes both EGFR and MET inhibition. Next slide. So the real question is how to select between these 3 preferred category 1 options. And when we talk about from pure scientific point of view, and the next, we know that there are a lot of limitations, logistic issues, and availability of these drugs as of now. So what is the most commonly used first line regimen in your day-to-day practice? So I first come to Dr. Jovita, and then Dr. Sushil, and then Dr. Neelam can take this question. Dr. Jovita, am I audible?
Yeah. Am
Yes,
I audible?
please go ahead.
Yeah.
Yes.
Okay. Hi, Dr. Tumojit. Just a little bit of correction. Actually, I'm from Adyar Cancer Institute, not Sri Ram Chandra Medical College. So now coming to the question, what is the preferred first line therapy when we have an case which is detected with the, EGFR mutation? So obviously, at this point in time, in an academic setup that I am in, if the patient is obviously affordable and everything, your choice will be osimertinib. But as a poor man's osimertinib, we do opt for pemicarbo with geftinib. And that also has given us very good results.
Perfectly acceptable. That's why I kept this question in 2 aspects. One is from pure scientific point of view, and another was what we commonly do. So I fully agree with you. In my day-to-day practice also, but the most commonly used or received regimen is pemetrexed platinum along with the first gen TKI based on the NEJ009 on the TMS Mumbai data. Fully agreed. Thank you. So I come to Dr. Sushil. Your opinion, Dr. Sushil?
Yes, sir. Hi, sir. Good evening, everyone.
Hello.
So,
Good evening.
what is, yes, sir. So, what is your preferred first line systemic option? Till FLAURA2, definitely osimertinib was my first preferred option. And once FLAURA2 has come, then I became very picky, or I do my clinical judgment and choose the patients who are eligible for the FLAURA2 regimen. Mainly, I prefer for the brain mets. And also, if the patient is young, fit, then definitely I would go with the FLAURA2 regimen, or else my go-to regimen would be osimertinib. And what is the most commonly used? Either osimertinib or, like ma'am said, it is PEM carbo with geftinib.
First gen TKI plus chemo. Yes, agreed.
Correct.
Perfect. Thank you. So, Dr. Neelam, any difference in opinion?
I absolutely agree with both of them. But yeah, exactly. The performance status of the patient and everything does play a very, very important role. So, and yes, same here, coming from a place where affording osimertinib is something that is a little challenging. So yes, and then we have good data from the Tata Bombay. So PEM carbo geftinib is a good option. And if not, obviously, after the FLAURA2 data, obviously, patient is fit and fits in the criteria, then PEM carbo osimertinib turns out to be the best option.
Perfect. Fully agreed. Next slide. So a few years earlier, our life as a medical oncologist was quite easy. So a patient comes in our OPD with classic EGFR mutation positive disease, advanced metastatic NSCLC, offer osimertinib, and they will have a median progression-free survival near about 1.5 years, near about 19 months. But after the publication of the MARIPOSA and FLAURA2, it becomes difficult for us for choosing the optimal therapy, which is optimal for a particular clinical scenario. So from a pure scientific point of view, whether combination therapies are required, the answer is yes, obviously required, because we know that we can achieve a much better median PFS in the first line, which is better than the FLAURA, which is better than 19 months. And the biologic rationale of this combination is just to overcome intrinsic resistance and to remove the residual disease with the cytotoxic chemotherapy backbone, which can be means remaining even after a good amount of induction exposure to the third gen TKI. Next slide. So when you talk about combination, there are two different class of combination regimens from scientific point of view. One is chemotherapy as a backbone when added with a third gen EGFR TKI. So examples like FLAURA2, which is osimertinib plus pemetrexed platinum-based chemotherapy. And the next one is again a different third gen TKI, which is aumolertinib, which is again a approved drug, third gen EGFR TKI drug only in China, approved only in China. And the trial name is ANIAS-2. Both the trial designs are quite similar. Even the reported survival outcomes are also quite similar. The second class of combination can be a non-chemo backbone regimen, which is added to again a third gen EGFR TKI. So it is used in a Mariposa regimen, which is lazertinib plus amivantamab combination. Now, all these three trials have suggested there is a significant amount of PFS and OS benefit over and above the EGFR TKI when used as a comparator arm as a monotherapy. But the only caveat is this survival benefit comes with a price, and that is the added toxicity as well as the logistic issues of multiple time hospital visits and need for admissions for IV infusions. So as of now, whether if we ask this question to us that whether these combination regimens are standard of care for most of the patients, probably the answer is yes, but certainly not for all of our patients. Next slide. So I come to Dr. Sushil. How really you choose your regimens in first line? Basically, this question is about choosing between an monotherapy, means osimertinib monotherapy, versus a combination regimen. And if you choose a combination for certain clinical or biochemical or molecular markers, then among the combination, how you really select between the amivantamab based combination or the FLAURA2 regimen. We know that as of now, the lazertinib availability is not there in our country, but still from a scientific point of view, you can give this answer.
Yes, sir.
Dr. Sushil.
So mainly I have experience with the FLAURA2 regimen, and I have a hard time practicing this regimen because most of the times we know that the patient is going to land up with the toxicity, especially bone marrow toxicity, that will delay the therapies. And sometimes, though we start with the combination therapy, at last we need to compromise the chemotherapy and continue only the osimertinib. So these are the practical challenges. And so hence I won't choose this regimen for everyone. Mainly a few high-risk patients I'll choose, or else I would go with the osimertinib. And choosing between FLAURA2 and Mariposa, I have no experience with the Mariposa. But scientifically speaking, I think FLAURA2 and Mariposa PFS is almost similar, 23 versus 25, just 2 months difference. Only thing with the Mariposa is that it has got dual EGFR, anti-EGFR activity, and also it takes care of the MET resistance mechanism. In FLAURA2, if at all the patient is progressing on the FLAURA2, the main resistant mechanism would be MET. So Mariposa basically address that anyway we know that the patient is going to have MET resistant mechanism. So why not target in the upfront itself? So that was the intention of the trial.
Agreed. Thank you. Next slide. So this is basically the forest plot of FLAURA2. It suggested almost all predefined and exploratory subgroups. The benefit of combination regimen, that means osimertinib plus pemetrexed platinum, is very well maintained when you compare with the comparator arm, which is the osimertinib monotherapy. Surprisingly, if we focus on the patients with a baseline CNS metastatic disease, the hazard ratio is 0.47. And that is much better than the overall ITD population. So that again suggests that patients with the baseline brain metastasis, probably this doublet chemo along with the third gen EGFR TKI is the way forward as of now. When you compare with the EGFR TKI, third gen EGFR TKI as a monotherapy. from pure scientific point of view, if we ask this question to us that monotherapy versus means osimertinib versus osimertinib plus chemo, then almost all the subgroups there is means no such subgroup that suggested that osimertinib will score better than the osimertinib plus chemo. But still, as we have discussed, there are logistic issues, there are issues of added toxicity. So probably from a pure practical point of view, elderly patients, frail patients, limited social support, and who have been facing logistic issues for multiple hospital visits and admissions for IV infusions, and not accepting the added toxicity issues. So probably those can be offered with osimertinib monotherapy. For all other high-risk subgroups, like said by Dr. Sushil, ideally a combination regimen is the way forward. But as of now, no clinical or molecular feature provides a clear guideline that which patients are the ideal candidates for a monotherapy or a combination regimen. So I come to Dr. Jovita again. In your day-to-day clinical practice, means how really you select patients who are the ideal candidates for osimertinib monotherapy, or means if money is not an issue from a pure scientific point of view.
I think, as the data go by that we have already obtained and we've been discussing, my definitive choice will be osimertinib. And just as, some other doctor alluded to, I think the ctDNA is also coming up a big way. So I think I have not incorporated in my practice yet, but looking at all the trials, it looks like if we have a very high ctDNA, then my choice would be to combine osimertinib with chemotherapy, which is obviously a little toxic, but it might be an important option to look at, especially if we have to have a good response.
Yes, fully agreed. So as of now, we have an ongoing phase 3 data. Next slide. Can we go to the next slide? So as opined by Dr. Jovita, this is probably the way forward, although we don't have any robust published data as of now. So this is basically EGFR Schrader's trial, again a phase 3 trial. Very short osimertinib induction, and followed by if the patients are still ctDNA positive, then their treatment is escalated with addition of either a chemo backbone or amivantamab. That means both the FLAURA2 or Mariposa regimen, or versus randomized to osimertinib, continuation of osimertinib as a monotherapy. And if there is ctDNA negative, then only osimertinib monotherapy. So this study will obviously answer that which will patients with high tumor burden benefit more, and easier to choose patients who will have maximum benefit with the combination. But as of now, this approach seems very encouraging, but investigational because we don't have any published data as of now. Next slide. So this has already been discussed, as Dr. Sushil has said, that means there is no robust evidence how to choose between two different combination regimens, as we don't have any comparative head-on RCT, no predictive biomarkers as of now. So decision has to be a shared decision making. But as per some of the commentary published after the Mariposa and FLAURA2 publication in the NEGM. So what is the basic consensus is that we can always choose our patient subgroups for where the FLAURA2 would be preferred or where the Mariposa would be preferred based on the coexisting conditions and comorbidities. Just like patients with renal insufficiency or baseline MET overexpression or amplification, always prefer a Mariposa sort of regimen, amivantamab lazertinib, because it's difficult for patients with renal insufficiency to offer platinum pemetrexed plus chemotherapy. And similarly, like patients with contraindications to anticoagulation, which is otherwise the prerequisite for offering amivantamab lazertinib based regimen, because as we know that from Mariposa that near about 40% patients with this combination having some sort of venous or arterial thromboembolism. So patients with contraindication to anticoagulation, either absolute or relative contraindication, always FLAURA2 regimens should be preferred. So these are real world settings. Some of the coexisting conditions or comorbidities can offer or guide us for choosing one combination regimen over another. But as of now, there is no head-on trial, and probably in future also we'll never have such trials. Next slide. So next, the important issue is that whether after the induction phase is completed, which is usually the 4 to 6 cycles, whether continuation of this pemetrexed or amivantamab for a long term till progression is like over treatment or not, particularly for patients who achieve a good response after induction. So practically saying, if we focus on the FLORA-2 data, then the duration of pemetrexed maintenance is only 8 months, near about 12 cycles. And the take home is that induction phase is the most important. And Mariposa subgroup analysis also suggested that median PFS is very much similar in patients who discontinued maintenance amivantamab due to toxicity versus patients who continue receiving amivantamab as a maintenance. But again, as of now, we don't have any published randomized evidence. So this decision has to be taken on case-to-case basis. Next slide. So now there is a very important aspect of whether patients who achieve a partial response or very good partial response or complete response after few months of initial third gen TKI, there is any need for local consolidative therapy or not. And there is a published phase 2 data from multicentric USA data, which suggested that there is a very significant improvement in the median PFS, but there are a lot of criticisms of this trial. And the major criticism is the heterogeneous population and heterogeneous local treatment. So the take home is multidisciplinary evaluation. So for this aspect, I would come to Dr. Karthik, our radiation oncologist. That, what is your opinion that regarding this trial and criticisms, and regarding the aspects of clinical implications in our day-to-day practice? Do you really think that our patients would have much better PFS, just like reported in this trial, if selected properly and added any sort of local therapy? Dr. Karthik.
Yes, sir. So, good evening, everyone. So, the thing is, as you rightly mentioned, sir, the selection of patients is very, very critical in these type of scenarios, because it is going to be a metastatic to start with. And considering a local therapy in a metastatic setting, we need to all the more be careful in considering the factors involved. So I would say that this trial had, as the criticisms has already been put up, it had a heterogeneous population, and also local consultative treatment was 60% RT, and also surgery was also involved. But if suppose the patient has a good performance status and it is only oligometastatic, for example, and only the lung lesion is critically present. And it also, we can consider taking an imaging before considering for a local consultative therapy. If the lung lesion is less than 3 centimeter and it's only a single lesion, similar to that, we can definitely consider SBRT in these patients, because there is definitely a clinically meaningful improved progression-free survival of about 8 months extra, which is definitely clinically meaningful. But this has to be considered carefully at the cost of reduced side effects in these patients. So that is critical.
Perfect. And regarding overall survival benefit, this trial, the OAS data was not published and it was not a primary endpoint. So regarding that point.
Yes, so we have to consider this only as a pilot trial, because we need to consider more patients, and definitely if we have only phase 3 RCT, we can confidently select patients for local therapy. As of now, we are selecting patients when there's a good performance status and low volume disease in the lung, and when they can be considered for SBRT, because the quality of life will not be affected in SBRT. But we need OS data to proceed confidently.
Perfect. Agreed. Next slide. So again, I come to Dr. Karthik. So in North Star, one of the criticism is that less than 50% patients actually underwent PET-CT or any metabolic scan before choosing for or selection for local consolidative therapy as a radiation or surgery. So do you think that that is a criticism or that is a drawback of this study, or metabolic scans are absolutely mandatory for choosing patients for local consolidative therapy? Or do you think that we can always go away with normal conventional CT scans?
Normal conventional CT scans is also okay, but I would say some sort of imaging is definitely necessary, either a contrast enhanced CT of the lung or a PET-CT. PET-CT, why we are saying is we can also calculate the standardized uptake value, whether that lesion is definitely be considered, because if it's a radical curative intent setting, we will definitely consider all the lesions. But if suppose we have a lesion and we are selecting one of the lesions which is giving the symptoms, then SV also will be taken into account. So in that case, I would suggest a PET-CT is taken, we calculate the SUV, and also the lesion size is very important, so that a single image has to be taken before he's been taken up for SBRT. So better to take an image and then proceed with the RT.
Perfect. Thank you. Next slide. So how do you manage patients after progression on first-line therapy? So we have three different category one preferred recommendations. One is osimertinib monotherapy, and other two are combinations. Both means with the third gen TKI, different third gen TKI, and along with either chemo or a bispecific antibody. So probably ideal would be to go for a tissue biopsy and to detect histological transformation and mechanisms of resistance. And if availability of clinical trial is there, then enroll our patients in a clinical trial setting. But otherwise, choose our therapy in a very conscious way, depending on the resistant mechanisms which have been detected. Problem is more than 50% cases, even after doing liquid biopsy or repeat tissue biopsy NGS, no detectable or actionable biomarkers identified in this setting, and chemo is the backbone of therapy. And if the patients are not exposed to amivantamab in the first line, then Mariposa 2 regimen is very much means encouraging data in the second line, which is amivantamab along with chemotherapy post progression after an osimertinib monotherapy. So I've come to Dr. Neelam with this backbone. With this background, that in your day-to-day practice, how really you go about your patients after progression on first-line therapy, particularly if they are exposed to third-gen TKI in the first line?
So again, we do have very limited options. So again, I believe systemic therapy comes out as a backbone on patients who have already progressed on the first line PEMCARB, osimertinib. The docetaxel turns out to be one good option, and there are other chemotherapy backbone. Again, as such, the best options are when we can use amivantamab, lazertinib. And again, now that post osimertinib, there's also upcoming data on new ADCs that has come up. So there is izolantamab, which is an EGFR HER3 bispecific. There's some data coming up on datopotamab as well. So these are some of the options. But again, talking in our practice, because of the limited options, systemic therapy. So again, at this point of time, I would like to do a repeat biopsy. Would like to identify the mechanism of resistance, whether it's an on-target, off-target, or if there's a histology transformation that has happened. That was also something that really plays a very important point. And yes, generally systemic therapy options is something that comes out as one of the options.
Okay. Next slide. So as discussed and mentioned by Dr. Neelam, that ADCs or antibody drug conjugates are one of the important therapeutic options post progression after an third-gen EGFR TKI. And datopotamab deruxtecan is already approved based on the Tropion Lung 05 and Tropion Lung 01 study. But datoderuxtecan usually the approval is in the later line of therapy after the failure of not only the TKI, EGFR TKI, but also the chemotherapy. So basically, approval is third line and beyond. But this year, ESMO in October 2025, this very encouraging data has been presented as a plenary session. So it's again a phase 3 randomized control trial, OptiTrop Lung 04. It again a TROP2 directed antibody, just like datopotamab deruxtecan, but the cytotoxic molecule or the payload is different. It's so name of the drug is sacituzumab tirumotecan, or in short, we called it SAC-TMT. So, but the data is in the second line setting. So 1:1 randomization between SAC-TMT versus pemetrexed platinum-based chemotherapy after progression on first gen, second gen, on third gen TKI. Now, when you talk about this baseline demographic characteristics, what is evident is that more than 95% of the patients are actually exposed to third gen TKI in the first line or second line. And the primary endpoint was progression-free survival. It was almost doubled from 4.3 months to 8.3 months, favoring the SAC-TMT arm with a very significant hazard ratio of less than 0.5. Next slide. But there are certain issues with antibody drug conjugates, just like in this trial also. So this OptiTrop 04 is exclusively done with South Asian population of patients, or more specifically Chinese population of patients. So before this regimen is being widely adopted, further work needs to be done, and there is obviously a need for a global phase 3 trial with at least Western population showing the similar sort of results. The next criticism is the comparator arm is actually the chemo means chemo only arm. It's pemetrexed platinum based regimen as a comparator. But as of now, the standard of care after the failure of a faced third gen EGFR TKI as a monotherapy, probably we would like to use the Mariposa 2 regimen, which is amivantamab plus chemo. So there is a high probability that if we use this amivantamab plus chemo, then the incremental benefit of this SAC-TMT would be smaller. And there are other issues of that we should be more confident regarding the managing of the toxicities. Next slide of this SAC-TMT. One slide back. Yeah, so SAC-TMT, particularly some of the differential toxicities like stomatitis or ocular toxicities, which are very difficult to manage, and there is always some learning curve of medical oncologists. So I'd come to Dr. Jovita. Do you have any experience, practical experience regarding using antibody drug conjugates, any of these drugs in real world setting, particularly for patients after progression of first line EGFR mutated NSCLCs? And what is your opinion regarding the practical applicability of this Optitrop 04? Do you think that means ADCs are now coming in a big way and they can replace the second line, and also they can come in the first line setting as a combination with EGFR TKIs? Dr. Jovita, am I audible? Dr. Sushil?
Yes, sir. So I don't have any experience of using these ADCs in second line or third line, sir. But even if we look at the PFS, it's just 2 to 4 months difference with a huge cost. So I think maybe in our real world setting, especially in a country like India, practical feasibility is issue. Let's see if it move on to second line and first line. If it is showing better results, if the cost come down, then we may apply it into the real world practice.
Perfect. So you are not convinced with the data and you need more robust data before changing your practice. Perfectly acceptable. So I've come to Dr. Neelam for your final comment, and then we'll wrap up this session. Dr. Neelam, your final opinion?
Yes, so I would agree again for the margin of benefit that we are getting with the datopotamab deruxtecan. We only have PFS data and the OS data still remains immature. So whether to use that drug for such a marginal benefit, even at this point of time, if we can change the practice, obviously no. But yes, maybe if we get some more data, then yes, maybe in future, and also that in our country, that if we have an access to the drug and financial toxicity, everything, if we are able to overcome, then so this is something that will be a good option that we can use.
Thank you. Fully agreed. So I'll stop here, and thanks to all our esteemed panelists for such a nice and active participation. And back to organizers.
Thank you, sir.
Thank you so much, sir.
Any of participants having any query, drop your query in the chat box.
Roshini, if there is no anything to be discussed, we will go for conclusion. I mean, closing remarks, or I think there are some questions in the draft bar, I think, box. I think. Anup, are you there?
Yes, sir.
No, I will ask. There are two questions in the chat box. I think.
I'm here, sir.
Arvind Chaturvedi has asked. He has asked. In lung cancer, we take account into the CPS score for immunotherapy, while others cancer take TPS. Why is this difference? You want to know? Hello.
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 Yes, I think finally it depends on the type of trial. Actually, different trials have used different platforms. For example, in the atezolizumab, they have used the Ventana protocol, and for pembrolizumab trial, they've used this thing, 22C3 DACO method. So, but the scoring system, I think most of the times they have used TPS score in lung in all these studies.
Absolutely, I think different immunotherapy trials acting different scores for I think is the reason why this is. But now there are studies saying that whichever platform you use, I think the immunotherapy seems to work if the patient is showing a high score. That is what the thing is. And the second question you want to know is, will neoadjuvant immunotherapy becomes the standard of care in subset of lung cancer?
Yes, sir. I think in patients with stage 2 and 3 disease, it will become the standard of care because more of the now we have more data for PCR and ctDNA and these correlations, and we know that with only adjuvant treatment, the survival outcomes are not very good. So especially stage 2 and 3, I think it will become the standard of care. Stage 1B probably not. Maybe surgery followed by adjuvant chemo and immunotherapy may continue to be the standard treatment. But stage 2 and 3, I think, especially PD-L1 positive, it will become the standard of care. So chemo with immuno followed by surgery.
Yeah, in a summary, as you rightly told in your talk, that immunotherapy, which started as a palliative treatment, now moved on in early stage cancer, also adjuvant, neoadjuvant, perioperative, all are here to stay. I believe that I think basically you have to choose which is the right patient for which strategy is the ultimately clinical decision which we have to make in the tumor board, sitting with molecular oncologist and everybody to decide which patient will go for a neoadjuvant, which patient will go for upfront surgery, and which patient will go for the perioperative option is the thing to be decided. But immunotherapy will remain as a part of the lung cancer treatment, which has contributed enormously to that of the lung cancer survival. I think in the second talk, Animesh did touch upon the adjuvant and neoadjuvant trials of TKS. I think Neo-ADAURA trial, after that, I think the neoadjuvant has coming up a very big way. We know adjuvant already it's a standard of care in lung cancer in a patient with EGFR or ALK positive. We do attempt adjuvant, but neoadjuvant, after the ASCO presentation of the trial, neoadjuvant is evolving. I think in a suitable patients, you can try that regime and give that regime also as a neoadjuvant therapy, I believe. I think in the panel discussion, I think Tamoje did touch upon the metastatic disease. So ultimately, we have to decide which patient will go for TK plus chemotherapy, will go for TK alone. I think he did more touch upon the clinical features which are determining now. ctDNA may be way forward. We have to see how it goes in the future. That are we going to do the treatment based on ctDNA levels or something that we have to look into that matter. I think overall, I would like to thank the speakers, moderator, panelists, and attendees, everybody for this wonderful CME. Thank you, one and all.
Thank you, sir.
Thank you so much, sir, for perfectly concluding the session.
I think you are audible. Your audio is not visible. I mean, audible.
There is a connectivity issue, so sorry for that. So I would like to thank all the esteemed faculty members for joining us today and all the participants who have joined all over the world. And I would like to inform to the participants that the certificates will be issued in 2 to 3 working days. Thank you all. Good night.
Roshini, I think some of them want you to post the video on YouTube. They want to watch. I think
that will be taken care, sir.
Okay. Thank you. Good night.
Thank you, sir. Good day, sir.
Good night.